Welcome, Meredith. Today, we're going to finally have that conversation about social work in the mental health setting. I really appreciate your willingness to talk about your more than 2 decades of experience in the mental health setting and your perspectives. Before we get started, I want everyone to know that Merideth Canham-Nelson is one of our instructors, has been really dedicated to our program, and she brings a wealth of experience to the classroom because she has such hands-on experience with a variety of clients in this setting. And I really look forward to this conversation that we're going to have about behavioral health today. You're on.
All right, great. Thanks for having me. Yes, so I wish I could see you all, but we'll do it this way. So my name is Merideth Canham-Nelson. I am a licensed clinical social worker. I received BAs in social welfare and psychology from UC Berkeley, and then I went on to get my MSW from Sacramento State. And next month, I will be celebrating 21 years of having my LCSW, being licensed. So just to give you a little bit of idea of what I've done, initially I did some work with rape crisis. I did some work in the foster care system. And then somehow, even though I was specializing in children and families, I ended up in the mental health setting. And I have worked in public mental health for probably about 23 years or so. And I've done a couple of different things within behavioral health. I worked in the schools, and then I also did case management for about 14 years. For kids that were in placement. So they were placed out of county and out of state. I provided mental health case management, making sure they were getting all their needs met while they were in placement. And they were placed by the education system, by probation, and by DSS. And currently I am the supervisor for a transition age program. So this is individuals between the ages of 16 to 26 who experience severe mental health challenges. So definitely working with things like psychosis, bipolar, severe OCD, anxiety, depression, things that cause, excuse me, things that cause people to maybe have multiple psychiatric hospitalizations, and at times having some instability in their mental health that requires us to step in and help them live the best life that they can. So that's a little bit about me.
That's a very broad array of experience there. I congratulate you for being able to move across those systems so effectively, because it does show the flexibility of our training as social workers, though. So that's a really great aspect of our training and the skill sets that we're promoting with our students so that they can be flexible across populations.
Yeah, and also just to put it out there, so within the mental health setting, so while I am a clinical social worker and do therapy, there are a variety of things that can be done. So working in a hospital setting, for example, on a locked mental health unit, a lot of that has to do with interaction with families, linkage with services after they get released from the hospital. You can, I was doing preventative work in the high schools when I was doing school work. So it was therapy, but it was really more like counseling, doing drug and alcohol groups and smoking cessation, and then just basic social skills. Then of course, case management. I loved doing case management. I'm a pretty organized individual. And so I was really able to keep track of everything and take a look at the bigger picture of what folks needed. So I wasn't doing a lot of therapy at that time. And then of course, with the setting that I'm in now, it is a lot of crisis intervention, a lot of very quick thinking, and helping to make sure that people are stable and have all of their needs met. So there's a lot of things to do within the mental health setting. It doesn't have to be just therapy. So.
Okay, so in your case management role, because we've looked at that in this class, your case management role, you're obviously negotiating a client contract and brokering, linking people to services in the community. Were these individuals that were being discharged from a mental health setting and needed additional support, or what did your case management work really look like?
So a lot of it was these are teens and children who had been put in placement. So they were in group homes or treatment
Uh,
centers outside of the county as well as outside of the state. So there was a lot of coordination to make sure that they were getting all all of their needs met. And by that, I mean, whichever agency it was that sent them to placement, the education system, probation, we wanted to make sure that the kids were actually getting the services to help address the issues that those agencies sent them to placement to get. And so not only making sure that they were, housed and fed appropriately and clothed, that their education was advancing despite being moved from their home school district, but also just making sure that the mental health services they were receiving were appropriate for what they needed. The other big part of that was interacting with the client and their families while they were out of the home, because we wanted to maintain that connection and make sure that the parents were as involved as possible. Again, even though their child was out of county and even out of state. So there was a lot of coordinating in that way, doing like multidisciplinary team meetings that involved the parents and treatment team meetings to make sure that everybody was on the same page. And then the biggest part of it was when they went home, because between the transition between group home living and going back home was a pretty sensitive time. And that was a time where a lot of the gains that were made could be lost. And so it was making sure that they were set up with all of the different support systems that would help them reintegrate back into their homes and back into their communities.
Okay, great. I appreciate your explanation. My first job as a social worker had a case management component, which was in child protection. And so I appreciate your explanation of kind of making those connections across systems for people, especially as we think about holistic care and the importance of making sure people receive the services that are due to them. Okay, so let's get going.
All righty. Okay, sorry. All righty, here we go. Okay, so the first thing I wanted to mention is that you might hear mental health and behavioral health as two different terms. They basically mean the same thing. We used to say mental health, but have moved towards more the term behavioral health because it's more inclusive. So it's the idea that we're promoting well-being, overall well-being, by preventing and intervening in mental illness, so things such as depression and anxiety. And a lot of times that has to do with helping people to live their lives a little differently and conduct themselves a little differently in the community so that they can stay healthy and well. Also, what has been added to this idea of mental health is substance abuse. And so the term behavioral health is really much more inclusive of both the mental health side of things and the substance abuse side of things. So if you hear both of these terms, they mean the same thing.
And this perspective really is really honors that everybody's at risk, right? That this wellness approach. So being in would you say it's even less stigmatizing?
I would say so, because, and I was just about to say that, is that with mental health, so you say mental health, the reality is we all have mental health, right? Just like we all have physical health. But somehow when you use the term mental health, people immediately think crazy. And so that's a lot of what we work with families, is about the idea that we all have mental health. Some of us are healthier than others. Some of us have more challenges than others, just like with physical health. And so the term behavioral health, it's more, it not only is it more inclusive of the variety variety of things that can impact people's well-being, but also it's it's less stigmatizing because it doesn't have that term mental in it, which connotes some sort of mental illness.
Gotcha. Okay. Thank you for that
For sure.
explanation.
Yeah. Let's see. So some of the historical perspectives of mental health, the medical model. So medical model, it's still around. It's definitely what the DSM is based on. It really focused on the underlying problem as being within the person. And so that means that any intervention we did was really focused on fixing the person and fixing the individual. So things like distress and functional impairments were really manifestations of something the individual was doing. So you might hear like the disease model or the medical model. And so that's really what a lot of our original historical perspectives of mental health were. Then you have the psychological perspective, which this is really based more on stage theories. So you may have heard about these in the human behavior class. So these are based on life stages. So essentially they're theories. So we're looking at things like Erickson and Kohlberg with his moral development, even Freud with his psychosexual development. And so the idea that there are universal consequences across the lifespan that everybody goes through, and how a person manages or overcomes those stages depends on how well they're going to do in subsequent stages. So early stages impact what is going to happen later in the person's life. And so an unsuccessful transition from one stage to the other is where the challenges, abnormalities come into place, maybe even at the time being called deviant behaviors. And so it's all based on a person's ability to maneuver through these life stages.
Okay, so this really does pull in our human behavior theories in. So it really requires that we be very knowledgeable about the life course and the different stages that we're moving through. And that kind of really also brings in that trauma-informed care, because if you have a trauma at an early stage, some of the unresolved issues there can become blocks in a person's growth and development, right?
Mm-hmm. Absolutely. And while the medical model still, while it's not our primary model, it's not what social work is based on, we still use it. Same thing with these psychological models. So it's not necessarily what we base all of our social work on, but they're absolutely important to know. One of my more favorite people at the moment is Bruce Perry. So you talk about trauma and his perspective on the idea that there are these 6 core strengths that people need to develop, and that trauma will definitely impact those. So whether it's the psychosexual development, the psychosocial of Erickson, even I always throw Kohlberg in there as moral development, or Bruce Perry, we need to be paying attention to those as potential explanations to help us understand where the person has been and why they're behaving the way they are now and why they're having the challenges they are now.
Yeah. Thanks for that explanation.
Yeah. Okay. But we are social workers. So we have a social work perspective, and that is person and environment. And so here we're really taking a systems approach. We're really looking at all of the systems that the person is interacting with, and how those systems interact to either be a good fit for the person or maybe not such a good fit, in which case life becomes a little bit more challenging. So it's really looking at that ongoing transactional process between the systems that last throughout the lifetime. So what we're a good way to look at it is that, so then we can look, we don't just look at the individual as the place for where a change needs to happen. We look at the whole system. So it might be the environment that we need to help change for the individual. Maybe there's some biological components going on that we need to help them get connected with medical care. Then of course the mental health aspect, and then maybe their environment. So it gives us a lot of leeway to intervene at a lot of different parts of the person's life. And here's what I wanted to show you is just the intersection of how we have the biopsychosocial, and what I left off of there, which I think I should add, is the spiritual as well. And so all of those things interact to create a person's mental well-being.
Yes, and so we do have interventions targeting these different circles, right? And really being flexible as social workers to engage in these different spheres is really important. And certainly we don't want to contribute to stigma by just becoming oriented the medical model and not thinking about the social, emotional pieces of our greater environment. So I really appreciate this graphic. It really does have a nice intersection. And I do think the spiritual is something we need to be really cognizant of too, because that really leads to health beliefs and behaviors that we need to be aware of as social workers, especially when we think about diversity and difference, when people have different beliefs than we do, but still very much a part of who they are that really shapes the way they view and experience the world.
And it has a big impact on people's interaction with behavioral health systems as a helping system, because there is stigma. There are some of the religious beliefs that, for example, we've had individuals that really the family, while the individual was accepting of their mental health diagnosis and kind of where they were with their mental health, the family had a much more difficult time accepting mental health and the interventions that come with it as being the source of the problem, because spiritually and religiously, they were viewing the person's behaviors as somehow upsetting the gods, or that they had sinned in some way, that they had done something that caused the higher beings to be upset with them. And so we battle that in our mental health system for sure.
Yeah, I'm sure of that. There's lots of different faith perspectives on mental health and trying to and that's a particular kind of stigma, right? And people's adjustment when they have those spiritual communities is really critical also for us to try to bring faith leaders in our community systems to be a part of the supportive system of care.
Yeah, we definitely try to incorporate whoever is in that person's life as part of the treatment team. And of course, when we're dealing with adults in the mental health system, they have the right to choose who is part of their treatment team. And so sometimes we get permission from them to involve parents and family and other parts of their community that serve as big supports to them. Other times they don't let us, which makes it much more challenging, but we work with that, and we do a lot of psychoeducation, not only with our clients, but with family and anyone else who might be involved with them and in a position to contribute to the person's well-being. So
can you describe, get a little bit more detail, what does treatment team look like and the role of the social worker in that particular engagement?
So in the public mental health system on my team, for example, we have BA level social workers who provide case management. They do a lot of the psychoeducation with family. They do a lot of the practice out in the community. So the case coordinator is a master's level social worker, and they're the ones who are really orchestrating as the facilitator of the treatment team, being the case coordinator. They're really looking at all of the different parts that need to be addressed. And not only that, but the one piece that they address is the therapy. So they will meet with the person weekly to actually do therapy to manage their symptoms. So for example, someone who's hearing voices, there's ways that we can interact with them and help them understand their symptoms, accept their symptoms in a way that they can learn strategies to make them less impactful in their lives and help them be more productive. And then the BA level social workers, as the case coordinator, is saying, hey, we need to connect them with housing, or they're saying they want to go back to school or they want to go to work. Let's get them involved with our supported our partners that will provide supported education or supportive employment. We might realize that, okay, the family is not completely on board. We're really needing to make sure that they understand what's going on. All of our BA level social workers providing case management and psychoeducation are bilingual. And so they're bilingual and bicultural, so they're really able to connect with the families in a culturally appropriate way to help them. Sometimes it's slowly bringing them on board. Sometimes parents totally get it right away. Another part of the treatment team is we do have psychologists on our team. So if we need any sort of testing, psychological testing that is beyond the scope of social work, that we can have them do that to help us with not only treatment suggestions, but also some diagnostic clarification. And then we have the psychiatrists. So we have psychiatrists to do the medication portion. And then of course, the client and their families are absolutely part of the treatment team. So
Okay.
those are all the parts.
And you did mention that sometimes a faith leader would be brought in on that if the client really wanted any kind of additional partners that they think are important in their lives.
Mm-hmm. Absolutely. If we start hearing a client talk about a particular faith leader or someone else in their community that is clearly it's someone integral to this person's life, someone they trust, we want to try and bring that person in, because if it's someone that the client really trusts, sometimes we may need to gear our interventions towards the client through that individual so that we can get the client's buy-in based on someone that they really trust being on board with it.
Yeah, so I really appreciate your description of the participatory nature of treatment team, but also the multidisciplinary nature of working as a team to really meet the needs of the individual and their family. I think that working multidisciplinary and getting feedback from each other and the different perspectives really does look at the whole person and really acknowledges that, yes, we need a specialist in medication, but we also need case management all at the table at the same time.
Mm-hmm. Yeah, so some of the community partners I mentioned the supportive education, supportive employment, helping them with housing, if they're homeless or they need looking at the person environment, if we need a setting that is more conducive to their mental health. We get involved with substance use programs to make sure that the person is getting those services, participating in those services, as well as that the substance use treatment provider is understanding the mental health component, because their specialty is substance use, right? Not necessarily the mental health. We also interact, which I know will be another one of the sections in this course, and that is the medical setting. So not only outside doctors that are addressing the person's physical health, but also hospital staff if the person ends up in the emergency department on a psychiatric emergency, and even if they end up in a locked facility, we need to coordinate and interact with those folks. And as you know, multidisciplinary teams can be a challenge because everybody is coming with their own perspective. And so it becomes really critical that we be able to successfully partner with these folks to make sure that the client's needs are met.
Yeah, that partnership is the right word, and it's important to make sure everybody's at the table in our treatment teams. I know that
Mhm.
for me, also as a social worker, especially when I was first starting out, I just learned so much from treatment team because of the variety of perspectives, and it really sharpened my sword, so to speak, as I was growing, especially as a young professional, to be around those multidisciplinary perspectives.
Yeah, and I'm thinking of one a particular program that I used to go to, a group home down in the Central Valley. Absolutely wonderful program. They were so successful with our uh, justice involved youth that mostly were gang involved as well. And I learned so much from the staff at that program. They were former gang members, for example, and so not necessarily formally educated, but wow, did they teach me a lot about gang mentality and how gangs, the structure of them works. And it really helped me to be able to understand my clients better and address the needs of my clients once they came home. So yeah, all those different levels are super important.
Yeah, well, youth in conflict with the law is a really unique area of practice, right? Because there's just these developmental issues that are going on around autonomy, and then obviously a lot of contextual environmental issues going on for kids that get involved in gangs, low quality neighborhoods in terms of stress and poverty. There's just a lot going on there. So having kind of an expert to guide that learning must have been really, really critically important to your growth and development. And I would imagine it's a perfect example of don't try to do that kind of work until you get enough training also.
Yeah, especially because I did do when I was doing groups in the schools. I was very green at the time. I was very new to the profession, and I was asked to basically broker between two sets of gang members at the high school. Oh wow! If I knew what I learned much later, then I probably would have done a much better job. But the bottom line is, remember that it's all about relationship and instilling hope in people. So at the very least, I did no harm, and I'd like to think I instilled some hope in them. But yeah, definitely, if I had known then what I eventually learned later, I would have approached things much differently.
Yes, indeed. So we've talked about a lot of different aspects of social work and behavioral health. And I know a lot of our students, this is really their goal, is to be in behavioral health as their long-term career plan. And I'm wondering, now that you kind of look back over two decades, is there anything that any kind of advice you would have given yourself as a young professional about developing this career and how to think about readiness to come into this setting and progress career-wise in a way that they can get their LCSW eventually and really have a satisfying opportunity to engage in behavioral health?
That's a good question. To be honest, I don't know if I would do anything different. I did work in just for a short period, couple of years in a couple of different settings. So I did rape crisis work and then foster care work. So those were really good because I knew a little bit about those areas. And those are two things that definitely are possible to interact with if you're working in a mental health setting. When I started at behavioral health, I really did not have any experience with the DSM or even a whole lot of therapy experience. And so I think being in case management, I was in it for a long time, like 14 years, but starting out with more like kind of counseling type stuff, which was doing the substance use groups in the schools. Was a good foundation because I wasn't really doing therapy yet. And then as I got into case management, then I started getting a little bit more into the therapeutic aspect. Also, one of the things that I did early on in my career with behavioral health is my team that I was on was was responsible for responding to the emergency department at Natividad for adolescent and child psychiatric emergencies. One of the things I did learn about that is I'm not a big crisis person, but that is definitely another aspect that people can do, and that is working on a crisis team in some sort of emergency department, or some counties have, they call them PETs, psychiatric emergency teams, maybe. So they're not necessarily in a hospital ED, but might be in a different facility that is specific for psychiatric emergencies. So I think I don't necessarily have any advice. I think, what I tell my students always when they're kind of amazed at all the things I know about, it's like, well, this is what 20 years will get you. It's just that time in the field. So I think just continuing to be open to learning new things and having an openness to understanding the different perspectives of the different team members, that will really take you a long way when it comes to working with mental health. Because like I said, we all have mental health. So we're going to interact with lots of different types of people.
Well, it sounds like just the diversity of experience that you've had, just so many different populations, and then systems like the settings like schools, really has been pretty powerful learning experiences that you've just built upon to bring you to this point where you're doing therapy as your main work now. Is that correct?
Yeah, so as a supervisor, I'm mostly doing supervision and mentoring, and just some leadership skills around making sure that we're covering all our bases to meet the needs of clients, as well as intervening when things are not going quite so well. But I do also have a private practice where I do psychotherapy. So,
Okay,
yeah.
great. Well, I really appreciate this conversation today. I think it really highlights some important aspects of the difference between mental health and behavioral health being more holistic, and then also some of our history moving from the medical model to more the model that social work is interested in with person and environment. I really, really appreciate this very simple graphic here with the biology, psychology, sociology aspects. And then of course, we want to overlay spirituality too, as we talked. So these are all critical pieces of understanding mental health and behavioral health as a career track for our entry social work students. And I think it's been a really useful conversation. Thank you so much.
Yeah, of course. Do we have some more time, or?
Sure. Yeah,
Okay.
if you've got more, I'm happy to have more. I thought this was the final slide.
Yeah, no. And I can go through these fairly quickly.
Oh, there you
But
go.
just keys to working in mental health. So one is to know the DSM. So whether or not you are going to be doing the actual clinical work, like I said, we all have mental health. We all come with mental health challenges. And so any setting that you're in social work, you are going to encounter people who perhaps have a diagnosable condition. And so just knowing the DSM, whether you know it back and forth, like the back of your hand, I don't think that's really necessary. Even after all these years, I still look things up. Well, a lot of times I'm looking things up just to make sure I've got all my bases covered, but at least knowing what your choices are when it comes to what could potentially be happening for your client. Developing case conceptualization skills. So especially as a case manager or within clinical work, is understanding the whole picture, like putting together all the different parts and noticing how that brings together the client's current issues and behaviors. So you want to have that skill of being able to look at all the different parts of the client. A willingness to seek supervision and consultation. No two cases are alike in mental health, and even with lots of experience, there's always some nuances that are different. And so being willing to seek some supervision and consultation to make sure that you get that you're getting the whole picture. And so getting assistance from someone else is always really good. The other part of that is regarding supervision, is learning to know your limits and boundaries. The engaging flexibility. Like I said, we deal with a lot of crises, and your day can be, yay, I'm doing paperwork all day because I have no appointments. And then all of a sudden, something goes sideways, and now your entire day is talking to various people and trying to coordinate things to make sure that your client is safe. Demonstrating patience, because it's patience with clients, because they don't always want to engage in the way that we think is best for them. Patience with family, as they begin to understand more about the mental health challenges of their loved one. And patience with the various systems that you work with, because they definitely don't operate quickly at times. Keeping current and accurate documentation, because of the the possibility for crises. We want to make sure that all of our documentation is up to date. It reflects exactly what we've done, so that anyone else coming next on shift, or you're off the next day and someone else needs to step in, making sure they know exactly what is going on so they can continue the great work that you've already started. And just the last thing, which goes with the willingness to seek supervision, is practicing self-care. I cannot stress that enough. Really developing within your practice things that you can do that are authentic to self-care and are sustainable, things that can be done all along the way to hopefully prevent burnout. But at the same time, some of these issues that come up really blindside us. And so we need to be willing to talk to our supervisor and others about what's going on for us, because we have mental health too. And so making sure that our issues and needs are being addressed while we're also taking care of folks that have very high and complex needs. So that's it.
So now we're at the end.
Now we're at the end.
So when you say know the DSM-5, part of knowing it is obviously just actually using it, knowing what areas to look up quickly. So knowing the anatomy of the DSM-5, like where to go, and then just being open to being reminded that we all need to go back and refresh as we get into really complex cases. So I appreciate you raising that, and that we all need to open that book again periodically.
Yep.
So, and I love flexibility. I always say I can't really teach flexibility to a student until I see that moment and I say, yes, I saw some flexibility here. And that's usually in the field setting where we're talking in field visits around the kinds of experiences our students are having. And I always say, we have to challenge ourselves to be flexible in how we think, how we respond, how we work with each other as peers. Really important to be effective as a social worker, is being flexible, because no 2 days are the same. No two clients are the same. And we need to really engage in a way that we can really, as I say, flex with that environment. So I appreciate that piece. And of course, keeping current documentation. People need to, if you get hit by a bus tomorrow, so to speak, somebody should be able to pick up your case, right? So that means really good documentation skills. And that's a skill that you develop over time. And our field placements typically will focus on that to supplement what we do in the classroom on documentation skills. So there's a lot of mentorship around documentation, I think, in my experience. Feedback from your field supervisor. So these are all important. Of course, self-care. What do you do for self-care typically? What are your things that make, I mean, I have some sense of it, but can you tell us what you're doing for self-care?
Yeah, I try and take time off when I need to. I try and do that as best I can. I make cards, greeting cards. And
Uh-huh.
something that keeps me very focused. I get very involved with designing and putting them together. So that is probably my best self-care. I also have 3 wiener dogs, and so my dogs keep me grounded and keep me focused on that there are other parts of my life besides work.
I knew the dogs were going to come up. I was setting up the opportunity for you. I know that they're really a big part of your happiness, and so I'm glad that you were able to tell us about your wiener dogs.
Yeah, anyone who takes my classes will probably eventually at some point see a picture of my dogs in the slides.
There you go. Okay, so now we're at wrap up. I really appreciate your time. I think this has been really instructive. I think I've learned a few things and have a greater appreciation for what you're bringing to our program. Just impressed by how many different aspects of care you're able to talk about, and really appreciate you, Meredith.
Oh, thank you. Thank you. Thanks for having me.
Of course. Take care.
Okay, bye-bye.